May 4th, 2023. I'm Billy Nguyen, the Chair of the Public Health and Health Equity Subcommittee. I'm declaring that we have a quorum present for our meeting today. The purpose of this meeting is to act on important business related to the practice of natural medicine in the state of Colorado. The board will make its decisions on agenda items today based upon written materials provided for its consideration in advance of this meeting. The public is welcome to listen. The public should not address the board unless requested by the board. As a friendly reminder to board members, please note that some of the material contained in the agenda packet may be deemed confidential. In addition, the board should not discuss the issuance of confidential letters of concern or seek legal guidance in an open session. Such matters will be moved into executive session for discussion. Members of the public will be asked to leave the meeting during the executive session. After an executive session, the board will vote on agenda items discussed in the executive session. Thank you for attending today's meeting and for your interest in these important matters. And now I will take the role of the subcommittee members. So if when I call your name, you would respond with a yes or a present. Dr. Tina Gonzalez.
Present.
Thank you. Lundy. Dr. Estes.
Present.
Commissioner Buxton Andrade. Dr. Goodwin.
Present.
Thank you. A few housekeeping items as we get started. I'd like to ask everyone to turn your cell phones and pagers to silent, please. That reference to pagers might be a bit dated. And now I want to hand it over to Sam, the program director, for a few notes.
All right, thank you. William said the same thing about pagers yesterday. So I'd like to introduce staff on. We have Amanda Weirs and Kathy Duran, as well as Monica Sutherland on. And then I'd like to kick it over to the Assistant Attorney General.
Good afternoon. This is Brian Urankar with the Attorney General's office.
All right, thank you. Back to you, Chair.
Thank you. Now I would like to see if there is a motion to approve the minutes from our last subcommittee meeting.
And we can pull that up right now.
Thank you, Sam. Sorry, we do have the those minutes are in the meeting packet, and I don't know if we'll scroll down to them. I see, recognize Dr. Goodwin, your hand is up.
Yes, Chair. So yesterday, Mr. Dunn did something with Sam. Maybe Sam, you can tell us a little bit more about what he did. Something about the meetings that we voted in to make it easier.
Yeah, no worries. Yeah, absolutely. So basically, to streamline the process, we'll approve the minutes at each of the next meetings. And then we'll ask to delegate authority for me to sign off for everyone. So I don't have to send it out to multiple people each time.
Okay. Yeah. So how do I do that? Do I just say I'd like to make a move to make Sam the signature authority after we approve?
Yeah, my understanding, and Brian, correct me if I'm wrong, we should approve the minutes first, and then we'll have a second round of motions to delegate Sam as I don't know, completing, let's see.
Just delegate the authority to sign the minutes on behalf of the subcommittee.
Okay, so I make a motion to approve the minutes.
Thank you. Is there a second?
I can second. I read them.
Thank you. All in favor of approving the minutes from the last meeting, please say aye.
Aye.
Any opposed? Any abstentions? Okay, the minutes from the last meeting are approved. And now, is there a motion to delegate responsibility to Sam for maintaining the minutes for future meetings?
So moved.
Is there a second?
A second.
Thank you, Dr. Estes. All in favor of delegating authority of minutes to Sam, the program director, Sam Barami, for future meeting minutes, please say aye.
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 Thank you. Anyone opposed? Any abstentions? Okay, so the authority for the minutes are now delegated to the program director, Sam Barami, for future meetings. Thank you all. So moving on to the first agenda item. We are going to begin with prioritizing the questions that this subcommittee will address, including identification of the first question, or we might consider a bucket of questions for the subcommittee to ask. And in that regard, I believe the board received an updated packet prior to the meeting with the questions that are now in front of us on the Zoom as the universe of questions per our last meeting that the subcommittee might consider, and want to open it up for discussion about which questions we want to address first. Dr. Gonzalez.
Thank you. So I got these ones today, but I don't think they deviated away from the ones that we had originally had. I think the structure was a little bit better, but I was reflecting on the ones in our conversation after our first meeting. And so I wanted to try to figure out how we can jump on to work that is already being done in the state around health equity. Last year in 2021, there was a Senate bill that was passed, Senate Bill 21-181, which was the strategic plan addressing health disparities. Sorry, I cannot talk today. I'm so sorry. And through this bill, there was actually a health equity commission that was developed under the Department of Health Policy and Finance, which is HCPF for short. And the Health Equity Commission is actually led by CDPHE. They just published their first report, and they have a definition for health equity that I think fits beautifully with what we're trying to do. And it's not broad, but it's broad enough that we can kind of tuck natural medicine kind of under there. And since it's kind of run by HCPF and CDPHE, it's really also addressing health disparities with healthcare coverage, specifically Medicaid. And so I think it kind of hits on some of the discussions we were having. So instead of trying to reinvent the wheel, I'm wondering if we can all read this, digest it, and see if it's something that we can kind of incorporate and use some of the work that they've already done to kind of help build our scope and kind of framework for where we're trying to go with the work that we're trying to fulfill. And so if it's okay with everyone, I can share the report with Sam, and if Sam can get it out to the rest of you guys, we can kind of look at that and see if my brain's going in the right direction, or if everyone wants to reinvent the wheel and create our own kind of work, which I don't think anyone would opt for, but you never know. That's just my recommendation.
Yeah, Dr. Gonzalez, thank you. If you send that to me, I will share that with everyone after the meeting.
Awesome.
Dr. Goodwin.
Yeah, Dr. Gonzalez, I'm definitely all about not reinventing the wheel. So thank you for that. I guess my question is, I'm not familiar with that bill. Who is it written for? Is it written for like medical providers and licensed practitioners, or because one of the discussions, and I brought it up last time, is we haven't quite figured out who we're writing this thing for, right? If we're going to consider these practitioners to be like wellness practitioners, or if they're going to be medical practitioners or whatever. And so, I'm just trying to figure out who that document was written for.
So it kind of all of the above, but what it is written for and why it was kind of created is because they wanted to kind of see kind of the equity of just healthcare in Colorado alone. And so where are the disparities, and where are kind of the they call them healthcare deserts because there's really no providers, but there's communities that still need those services. And so they really wanted the data to support the work. And so they're looking at the patient first, seeing what kind of facilitators, practitioners, medical doctors are needing, and then kind of how to bridge that gap. And so before, and the reason I was kind of looking at, okay, what's already out there is we would be flying blind if we didn't have a specific location in the state that we needed to kind of focus in on, an idea of kind of who our patient population is going to be before we kind of discuss, okay, then what kind of providers are going to fulfill that. And so we need to kind of find the demand before you actually fulfill, like, because you can license everyone, but if you don't have patients,
Right.
or if you license everyone in Denver and it's Baca County that's needing the service, then you're kind of doing a disservice to our work and to Colorado in general.
Gotcha. Yeah. Okay. Great. I'll look forward to reading it. Thank you.
I also totally agree, and I love the idea of aligning with work the state's already doing. I would note that the Oregon, they're kind of, our counterparts there also have a definition of health equity in the regs that Sam circulated prior to the meeting. So I think my inclination would be to start with the state definition, but also consider what Oregon did in this context and see if there's anything to be learned there. I also, in terms of the conversation we're just having, I kind of think of this as two very interrelated questions, and it may be one definition, but how do we apply it to patients, right? How do we ensure that access to natural medicine services is equitable? And then also to the providers, those participating in the continuum of delivering the services to the patient. So the facilitators and the healing centers and the people growing the medicine and those sorts of things. And how do we make sure that there's equitable, ability to serve those roles? And both, that's complementary to making sure that patients have equitable access as well. I don't want to jump to any conclusions, but it does feel to me, and so far the conversation suggests that maybe the first question is to define what health equity is, and then maybe we think a little bit more about what it means for the different audiences. That doesn't preclude us from talking about other questions today, but I'm at least observing that we might be going in the direction of that being kind of the first official step, or for a set of questions that we would answer. Invite any feedback on that. Dr. Goodwin.
I have the Oregon definition pulled up if you'd like me to read it. Happy to.
Great.
They wrote, it's on page 5, number 34, health equity means the opportunity for all people to reach their full health potential and well-being without being disadvantaged by their race, ethnicity, religion, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities, or identities or other socially determined circumstances. So that's what Oregon wrote.
Dr. Estes.
I would like to suggest added to that is poverty, impoverished people, homeless people, people who are, I don't know the term that's used right now, but used to be intellectually challenged, meaning people who were born with lag times in development, for instance. I think those are specific categories of people that are often left out. Thank you for hearing me.
Thank you. I just remark that I heard that Oregon definition is really applying to patients, not necessarily to the exclusion of people being able to participate in the delivery of the services, but it felt like that was kind of the center of gravity for that definition. So we might want to either have two definitions or expand our definition so that it encompasses both audiences. Dr. Gonzalez.
So just to make sure, so are we going to be addressing then first is the health equity and core audience? Will that be our kind of first task?
That maybe that's the form of a motion. I mean, yeah, I don't think we can decide that now if we feel prepared. Someone could make a motion, I think, and I think it's something probably we would vote on just to be sure. But that
So
sounds
can I
good to
make
me.
that motion
for what it's worth.
that our
Please.
first line of business is to really look at a definition for health equity and then look at core audience? I personally don't think you can kind of answer any of the other questions cohesively if you don't have those first two identified. So I'll make that motion.
Thank you.
I second.
Motion. Thank
Goodwin.
you. Was that Dr. Goodwin, I think?
Dr. Goodwin seconds.
Thank you. All right. All in favor of prioritizing the definition of health equity and the audiences to whom that definition applies, or to whom this subcommittee is focused, I might say, in terms of ensuring equitable access, say aye.
Oh, aye.
Or raising your hand is fine. Some indication of approval. Anyone opposed to us prioritizing those questions? Is there anyone abstaining from the question from this voting on this motion? Okay, so the subcommittee has agreed to prioritize the definition of health equity and the audiences. Wants to say to whom that definition and our work there applies. So I'm going to ask Sam. I want to maybe ask you a question. Do we want to talk about? I mean, is it your recommendation for us to talk about some of the other questions and how we might prioritize those, or should we just continue to talk about the health equity definitional questions? And if that's the case, we might want to either pause or we just take the time between the next meeting. I don't want to make this meeting super short, but to review the commission work that Dr. Gonzalez referenced, and subcommittee members reflect and come back and try to decide on a definition at the next meeting. What would be your and Dora's recommendation in terms of that next step, if you have one?
I think I think I'll send out the report once I pull it up. I've been trying to find it on their website the past few minutes, but I would consider looking at some of the questions and whether they also might be subcategories to the prioritized question on health equity.
And
Makes
just to
sense to me,
echo
Brian.
that, yeah, just to echo that, that does track with the agenda. So I would say, let's stick with what's published in the agenda, go through all the questions, prioritize, and then return to discussing the topics.
Thank you, Brian. Okay. So inviting further discussion about other questions, whether some of them might be included under this first bucket of kind of definitional and audience related questions that we have decided will be our first priority, or just reflecting on other questions on the list and where we think they fall in terms of the prioritization of the questions overall. Does anyone have any comments about that? I have a few just brief notes that I jotted down in looking at the questions. Some in thinking about kind of bucketing of them, not necessarily thinking in terms of prioritization, but once we have our definition of equity and the audiences who we are prioritizing in terms of our work, there are questions on the list related to what barriers people face, perhaps different populations, different people in different circumstances face to having equitable access, in this case, to natural medicine services, or we might just consider sort of healthcare services in general as a guide for how we're thinking about natural medicine services. Another then is, and so so that is one bucket in my mind. Another bucket is what regulation, what can we recommend in terms of regulations and implementation of the program to ensure equitable access by patients. And then related or as a separate bucket, what recommendations can we make and what regulations can we kind of encourage DORA to implement that would support the equitable delivery of natural medicine services. So thinking about those who would participate in the continuum of furnishing the services to patients. And then the last bucket that I see, anyway, the last bucket I see relates to kind of the public messaging that the subcommittee believes would be necessary around these issues. So what is our message with regard to equity of access? What is the message around equity around the delivery of the natural medicine services, and those other kind of public and public health related communications. That's just my thinking for what it's worth on kind of how to cluster those questions together. Or ideas about that, or questions or comments?
No,
So
no.
you're saying, sorry,
Go ahead.
just wanted to hop in really quick. So you want to bucket, and this is just for my notes. We'll bucket by barriers for equity as defined from the plan that we're going to send out, and then another bucket would be education materials related to equitable access.
Yes, but there were two other buckets I mentioned in between. One is like ensuring equitable. So there's the barrier. I mean, maybe this is two sides of the same coin. It's like, what are the barriers and how do we try to minimize them? So how do we what policies can we recommend that would help people who might otherwise not get equitable access to be able to access these services in the same way that anyone else could. And then just this kind of same question, but in terms of who we are approving to be licensed, facilitators and healing centers, et cetera. And I see that Dr. Gonzalez has her. Does that answer your question, Sam? I kind of thought of it as, okay, cool. So Dr. Gonzalez.
Yeah. So I love, Billy, that I think we've been reading each other's minds with this. And so I'm kind of going in the same direction, but can I read a statement? So Kim Bim is the executive director for HCPF. And when Sam shares with you this report, she actually wrote a letter to the legislator while she introduced the health equity plan to them. But she says something that caught my attention, and it kind of plays into what you just said and some of the work that we're hoping to kind of facilitate. And so when we're out there trying to answer these questions, if we can kind of keep this, or if this helps kind of influence or be more proactive with our work. Do you mind if I read her paragraph really quick?
To me, thank you.
Okay, so she says, unfortunately, having more providers isn't enough. Research has shown poorer health outcomes result in a healthcare provider with unconscious bias and our lack of cultural sensitivity, treats people of color, women, people with disabilities, aging adults, and LGBTQ plus people. Such individuals are unheard and therefore receive less effective care. Therefore, the department is taking proactive steps to improve outcomes, address unconscious bias through standardized practices, address social determinants of health, bolster prevention and wellness services, and incorporate screening and counseling in chronic disease management. The department also sees the value of including non-licensed healthcare providers, such as peers, behavioral health aides, and community health workers, to build individual and community capacity to advance health equity. And I think she kind of groups and kind of says exactly what we're trying to get at. And when I read that, the first thing that popped into my brain is watching when the state legalized marijuana for medical purposes. Because it was criminalized for so many years, people didn't trust it. And people who were interested were afraid to ask questions about it, to kind of afraid that they were going to be stigmatized. And so I think learning from how that kind of rolled out and played out with the work that we're doing is really keeping kind of her sentiment at heart while we're trying to go out there to, I was going to say influence, but that's the wrong word, to promote and to encourage folks to kind of see this as a cultural medicine, or as a natural medicine, or as a way that people might be comfortable without feeling stigmatized that, oh my God, they're thinking I'm going to be pushing drugs on people or illegal drugs on people. And so I love that paragraph that she kind of put out there, but just wanted to share. So when we're out there doing the work or trying to answer these questions, just kind of keeping in mind, like, oh yeah, there are providers who maybe aren't not wanting to learn, but might be afraid to start asking some of those questions.
Thank you very much. Dr. Estes.
Thank you. Could we, when we use initials for organizations that we're all familiar with, can you say the name of it in full so people who are listening know what organization or office you're speaking about? I think it would be a good thing. Thank you.
I think that's good advice. Thank you, Dr. Estes. I'll try to encourage us to use the full name so that anyone watching can understand who that is. And on that note, it's Kim Bimsteffer. Those of us who know her call her Kim Bim sometimes, but that's the person who leads HICPUF, who Dr. Gonzalez was referring to.
Apologize.
Dr. Goodwin.
Yes.
No worries, or not here at least. Thank you, Dr. Goodwin.
I was a little confused when I read these questions. For some reason, I thought it was talking more about how we were going to apply health equity to providing licenses for facilitators and health centers. Because it sounds like a lot of what Dr. Gonzalez is talking about is from between facilitators and clients. I thought it was about how the state was going to ensure equity in licenses, and because as some of the, I said in some of the conversations as Prop 122 was coming together, and there was always a concern that like big money was going to roll in and it was going to kind of keep some of the underground players from being able to access it. And that's why they wrote a lot of that, like they didn't want advanced education as being a requirement to get a license and that sort of thing. So I thought this work was about making it equitable for people to become facilitators and health centers. Did I read that wrong? I was super confused.
I'm happy to if Brian wants to give a read, I'll share my opinion, which is that it's both, that the charge of the subcommittee, as illustrated in the questions, is both, and I think they're interrelated, but equity of patient access to the services and also equity in who the state recognizes as people qualified to deliver the services. I don't know if Brian, kind of from a legal perspective, if you have a comment, or
Yeah.
Dr. Goodwin, sounds like you have something else to say.
I would agree with you, Billy.
That's great. Thank you for the clarification. Yeah, I was reading all these wrong. I was looking at it from a different lens. So I appreciate that.
I'll just say there's some interesting questions embedded here around it, and this kind of illustrates the point around insurance. And I think there's kind of two very big buckets of insurance to think about. One is it conceivable that these services would be covered by insurance, private or public being Medicaid, Medicare, Veterans Health Administration, et cetera. As a means of at least promoting equitable access, certainly will not solve the issue of equitable access, but I think would be a strong step forward if we can try to make recommendations that structure these programs in a way that insurers will consider them coverable. And then from a, I'm just going to use the generic word provider, that's kind of imperfect because we're talking about people growing and healing centers, but the providers of these services, what kind of liability protection do they need? What kind of medical malpractice insurance might they need in order to feel safe delivering these services? And those are complicated questions. I think they fall under the charge of this subcommittee. Dr. Gonzalez.
Cool. So Josh, did you just inadvertently give us our path forward? Since we're the way I look at it and the way you're looking at it, I think they mesh beautifully together, because you need to license the right person, but you're licensing them to treat who and kind of what their patient population is. And so I'm curious, or I'd be anxious to see if you had anything that you were kind of looking at as well from your angle, similar to the health equity plan that Colorado kind of put out.
Yeah, well, I mean, mostly it was from kind of restricting the requirements of in advanced education, and some people who may, be economically disadvantaged, they may not be able to get higher levels of training and things. And I know that was a big concern for people who wanted to be facilitators. And when I looked at the Oregon regulation, their social equity plan, it's like one page, it's like 7 lines, and they basically, want as part of their application for the facilitators to have a social equity plan. Like, how are you going to, try to get a diverse client population? But it wasn't really in depth. And so, no, I thought our role was just to make sure that at the state level to get licenses, we were there. But I wasn't even looking at, kind of where you're bringing it. And so I'm so glad, I'm glad you're here. Thanks for that. I hadn't even considered it.
Yeah. No, when you read the document, they do look at providers. And then it's interesting that you work in TRICARE world and I work in Medicaid world. They're kind of similar, but they're very strict. And so I think that's where Kim and her administration are trying to go with health equity, that just because you don't have a medical license shouldn't mean that you are barred from treating someone. And I hate to say medically, but emotionally, behavioral. So that's why she's really looking at peer-to-peer, and we're actually starting to be able to bill. Peers can now bill Medicaid for some of their peer-to-peer services. They don't have a medical license, they just have life. They know exactly kind of how to coach someone through. And so that's kind of the lens I'm looking. So I was kind of on there with you, but I'm really looking at it from a patient's eyes. And because that's where we look at first, before we even bring someone into the network to actually bill for some of their services, is really who is your patient population, and are you bringing in a new service that we don't already currently have? Not that we're not going to contract with them, but we kind of want to look at that diversity, like what else can you offer to our patients, so at least they have options to explore and go to. And so, sorry if I went down a rabbit hole, but I think we'll meet each other.
Yeah, no,
sooner or later.
I'm happy to go into your rabbit hole because I'm falling to your expertise here. Thank you. I don't know if this is a good time to say this, but I will say that when I was looking at the informed consent documents that Oregon pushed out, they have a line on there that specifically says, you understand that this is not a medical or a clinical practice. So they kind of took a hard line there. And I think if we are going to eventually want some insurance support, we're going to have to make sure that we don't, go that hard with it. And as we talked about in the other subcommittee, we might have to build different paths. And Dr. S's recommendation was, making it horizontal, not one's better than the other, or, a tiered system, but some different pathways to get there in order to meet this kind of health equity thing. And it might be a good spot for our subcommittee as we kind of lay it out.
Yeah, so I like that way of looking at it, is like just different doors that people can go through that have, slightly different definitions and maybe different kind of licensures associated with them. And I think you might have been referring, Dr. Goodwin. I think a lot of committees are probably talking about the licensing subcommittee. I'm also on, and I know was talking about different categories of service, and therefore different categories of licensure that would correspond to those different categories of service. I very much align with your suggestion of making it a horizontally oriented mindset and program. Sam.
Yeah, I wanted to agree with you there on considering what's called the tiered licensure model. I think we'll see as we move forward with the work that it will or can be more equitable.
Dr. Goodwin.
In terms of the insurance piece, and I know we can dig into this more, we have a mental health company. One of my therapists does equine therapy. So she is a licensed provider, and she charges for one-on-one sessions, but insurance won't pay for equine therapy. A lot of them, they're the same with family therapy, which is crazy. Your marriage counseling, rather, they won't pay for marriage counseling, but they'll pay for a one-on-one. And so, we might run into that issue too, where it is okay for you to be doing this, but they're not going to pay for it. And so those might be some of the things that we're going to have to address while we're doing this as well.
Yeah, agreed. And I am interested to dig into those issues. And there are, I think in a prior conversation, somebody raised the analog of acupuncture or other services that some insurers cover and some don't. And I do think it would be beneficial to some degree think about these services as services rather than the analogy being like a prescription for a drug. And I think that's actually the truth of the situation, because we have the three-part model of the prep and administration and reintegration, and there's really, the medicine is one piece of a much bigger constellation of services. Sam, you want to say something?
Yeah, I just wanted to clarify. So what I'm understanding from this discussion, on the questions list, number one is number one in the prioritization list for you all, and then would it be 2 as a second one? What are the greatest barriers to ensuring health equity? And then 5, what measures can be taken to ensure equitable access to natural medicine therapy and its subcategories? And then it would go to 6, how will this relate to insurance for those participating in the delivery of the natural medicine services? Does that sound right?
That's sounding good to me. And then there's also on the list, as maybe, I can't remember what number we were at, but the next one would be the public health, the public communications about all of the above, in my mind. There's also this kind of like special issue of financial transactions and how those providing the services can receive payment, including banking. And that when we get to the issue of how they get insurance, maybe we kind of just fold that in under that bucket for organization's sake, even though it's a little bit separate. That's just a thought. How are other subcommittee members feeling about the prioritization of questions that Sam just outlined? We could perhaps consider adopting those via motion if folks are feeling comfortable. More discussions also welcome. See a thumbs up.
Yeah, I'm good. I'm ready to move when you are.
Right. Is there a motion? And let me repeat back, and this will be a way to check to make sure we all got it right here. To adopt Sam's suggested prioritization of the questions, where we go from the definitional question we've all agreed is number 1 to number 2 on our list in front of us. What are the greatest barriers to ensuring equity? Then to 5, measures can be taken to ensure equitable access to natural medicine therapy, and the sub questions underneath it. Then to 6, which relates to equitable participation in the delivery of services, i.e. facilitators and healing centers, et cetera. Then to number 4, in terms of the public facing educational materials. I think we can probably include in that materials that will need to be furnished to the deliverers of the services in a kind of a broad, let's call it kind of a, like not in the course of their licensure, but in like a broad, publicly announced kind of way. And I think that's it. That Sam says thumbs up. Okay, so that's what's on the table. Is there a motion to adopt that prioritization?
So moved, Dr. Goodwin.
Thank you. Is there a second?
I can second.
Thank you, Dr. Gonzalez. All in favor of approving said prioritization of questions going forward, please say aye or raise your hand.
Aye.
Thank you. One quick question of order, Brian. I vote on. Can I make 2 questions? Can I make a motion or second a motion? And 2 is, do I vote on motions as the chair?
You can make the motion yourself. I think just generally it's discouraged. It's better if someone else makes the motion. But you can, and yes, you do vote.
Okay, then I also vote yes. Anyone opposed to that prioritization? Okay, any abstentions? Okay, so the motion passes and we have accomplished our prioritization of our questions. Thanks, everybody. The next item on the agenda is to I will characterize it as continue our discussion about priority number 1 that we agreed to, which relates to the definition of health equity. Are there further comments or questions that subcommittee members would like to raise regarding that? Sam.
I will send out the plan after the meeting from the Office of Healthcare Policy and Financing, HCPF. But Dr. Gonzalez was able to send it over to me. And I'd like to read the definition to you all, and you can consider it for the next meeting as well, and review it and review the plan and how it might apply. And I'll see if we can also potentially get someone from HCPF, Healthcare Policy and Financing, from the commission to come speak to the board if folks would be interested in that. I think they might have a presentation on their website, but I'll have to double check that. But if it's fine with you, Chair, I'd be happy to read the definition as I have it. And I think it's on page 16 of on their website, on HCPF's website.
Great. Yes. Sounds good. Thank you. Please go ahead.
All right. Health equity is both an outcome and process. Health equity happens when everyone has equal opportunity to be as healthy as they can be. No one's race, ethnicity, disability, age, sexual orientation, gender identity, socioeconomic status, geography, or preferred language should negatively affect their health care. Health equity work includes removing obstacles to positive health outcomes, such as healthcare access barriers. And then there's a clarifying paragraph under it. The department embraces this definition, and with the direction of the Centers for Medicare and Medicaid, CMS, we are working to advance health equity by designing, implementing, and operationalizing policies and programs that support health for all the people served by our programs, eliminating avoidable differences in health outcomes experienced by people who are disadvantaged or underserved, and providing care and support that our members need to thrive. That's it. So, Dr. Estes, I think it actually touched on what you had mentioned regarding you wanted to consider something in the board's under definition or consider definition for health equity. Let's see. I think, let me see where it is. I have it in my notes. But you wanted to add a definition to it specifically. Oh, considered impoverished. I think it's socioeconomic status.
Dr. Estes, please.
Sometimes it's best to spell it out more specifically for this reason. And just give you one example. In Denver, I'll have what's called low-income accessible housing that is being built. The cap on what's considered low income in Denver is $85,000 a year of income. That's beyond the pale for many, many people. And yet the way that it's worded on lower income accessible housing includes people who, a lot of people who have far less money than that would consider a lot of money. So sometimes being more specific about the groups, I really like that Dr. Gonzalez mentioned ageism, elderly, the elderly. That's a really important category. my father was in his late 80s, and I would take him around from doctor to doctor, and some doctors would just say, well, he's old, what do you expect? That is unacceptable. That's not okay to treat the elderly people that way. So, and not everyone can have an advocate standing there to try to help the elderly receive their care. The same is true of people who are, we're 21 years US Air Force. My husband served for 21 years. And I served as a wife, which, trust me, is like being in the Air Force for 21 years. And trying to get access for normal health care, if you are a dependent, is an issue in TRICARE for Life. And so my point is this: if we could say disabled people, if we can say special needs people, if we can say people who have no home, who have no place other than the street, if we can say the elders, if we can say people who are not insured, people who are underinsured, if we could say things like that as subcategories of the good categories you've all put out, I think it might be useful, and it would be different than what other people are doing, perhaps. But it's more, I like the precision of it. So just my 2 cents worth. Thank you.
I have a thought. I mean, in that regard, and hearkening back to the passage that Dr. Gonzalez read from HCPF, I guess I just want to say that we have some hard work to do to meet our goal of ensuring equitable access to these services. Knowing what I know about the rest of the healthcare system, as I think all other subcommittees have very in-depth exposure and involvement with it, I don't think we can say we have an equitable healthcare system in Colorado or anywhere else, despite incredible efforts among other agencies and many people in the community. So I think I just really take inspiration from Dr. Gonzalez's quote, because one thing that it speaks to for me is just saying we aren't going to have policies that are discriminatory is not nearly enough. We have to be very proactive to create policies that can help enable people who are potentially marginalized, otherwise facing barriers to accessing services to access them. And so that's at least how I'm thinking of it, and that is not going to be easy, I guess is what I want to say. But I'm here for it, and I believe that the subcommittee is. I'm optimistic that we can make some serious headway here. We're going to be, anyway, perhaps forging new ground in healthcare in this very interesting and new space. So, for what that's worth. Do we have more comments or questions about the first question around health, the definition of health equity, that anyone wants to raise? And maybe I will include here any resources or items we want to ask Dora to consider preparing or bringing to us before the next subcommittee meeting. Dr. Goodwin.
I would like to, take that the most recent definition from that document that Dr. Gonzalez was mentioning, and just make it the base template that we're going to start working from. So at least let's pick that, lay it down, and then we can adjust it as we need. But I think it is, it sounds like the 80% solution for us anyway. And then we can get in there and kind of tailor, but I think that'll give us a start. So, Chair, if you're okay with it, I'd like to make a motion to make that the template that we start working on.
I second. Dr. E.
Thank you. We have a motion made and seconded to use the definition that is in the HCPF et al. Commission that has been created by them of health equity as the template, the starting point for the subcommittee to work from, perhaps with some, potentially modest modifications by the next meeting. But anyway, all those in favor of Dr. Goodwin's motion, please say aye or raise your hand.
Aye.
Aye.
Okay, aye. Any opposed? Any abstentions? Okay, that motion is approved. Other questions, comments, requests for resources from Dora relating to this first priority question?
So I think you answered the first priority question. So if there's anything related to two, and I'll send out the packet from HICPUF from Healthcare Policy and Financing, but just wanted to flag that. Congrats.
Yeah, we're making progress. I do want to open up that space for board members subcommittee members to reflect on the words of that, and I think we might want to build in a brief time to entertain any wordsmithing at the next meeting. Dr. Goodwin.
Yeah, Sam, if you could just send us out that definition like on a Word doc, and then we can each kind of brainstorm, and then at the next one we can get it together. That'd be great. Thank you.
I'll do that.
I like how Sam thinks, though, that we're together, and I have a little more time, so we have more time afforded for this meeting. Would we like to move on to the next question that we agreed to prioritize, which relates to Sam, why don't you tell me? I feel like you're going to get.
Sorry, I got a call from another board member. I was just clarifying to them that public health and health equity is happening right now. So I missed what you just said.
That's okay. I was going to ask you to remind us what we agreed is the second priority question that we might want to go ahead and start discussing now.
So we said it would be number 2 from questions to address. So what are the greatest barriers to ensuring health equity as it relates to the public accessing of natural medicine services, as it relates to licensing, product cultivation and testing, healing centers and facilitators? And how do we support marginalized populations in obtaining licenses and succeeding in the cultivation, facilitation, and healing center arenas?
Dr. Goodwin.
So please correct me if I'm wrong, anybody. My understanding is that they were trying to prevent what happened in the cannabis industry from happening now, and with the psilocybin thing, and the idea that only people with big money could come in and open dispensaries and took control over that, and they want to prevent that from happening so that we can kind of keep the network that's currently in place, and all these people can legally kind of distribute. So I think kind of the one issue here is keeping it so that anyone can get access to it, within certain restrictions, right? And I don't exactly know how to do that, or anyone's got some ideas on kind of where we might have went wrong when we did the cannabis thing. I'm not super versed on it, but that would be helpful for me just to make sure we don't make the same mistakes. But I do think that's one of the issues. Like, we don't want to do that again.
Sam, and I think I know that you actually have some good expertise of the marijuana story in the state. Is there a resource out there, a report, a retrospective analysis of how that industry unfolded? I mean, it's not a perfect analogy, I want to know, at least in my opinion, but it may be a helpful, informative analogy in terms of especially from the perspective of the deliverers of in this case, the product. So because I have a faint unfamiliarity with kind of the problem that Dr. Goodwin is in the phenomenon Dr. Goodwin's referencing, but I can't say I know enough to really have a sophisticated opinion about it. So if
Yeah,
there's any resources like that.
yeah, if there's resources like that, I can ask around. I think there is. I can reach out to uh, ENC from the governor's office and folks at Department of Revenue and MED to see if there's any materials as it relates to that. Absolutely.
I don't know who did it first, so I'll go with Dr. Estes next, and then Dr. Gonzalez.
Go ahead to Dr. Gonzalez.
Oh no, this question I actually had for tomorrow's for the indigenous and religious use, but I think it plays in here as well. So I grew up in New Mexico, and our Native American lands out there are sovereign nations, and so like marijuana was legal forever. It just, you couldn't bring it in, you couldn't cross the Navajo, you couldn't leave the Navajo nations with it on your person. Is Colorado similar, where the Native American are the indigenous lands? Are they sovereign nations in Colorado as well?
I'm by no means an expert in this area of law, but generally, yeah, if you're a federally recognized tribe, you have sovereign status.
So I am curious. So the greatest barriers to ensuring health equity. I'm curious if they have already dived into that in some of the sovereign nations. And we can kind of lessons learned from them. Kind of how they distinguish between, yes, this is use, and no, this is just recreational use. Which might kind of help us look at the barriers of health equity on sovereign lands.
Yeah, and I can reach out to CCIA specifically. It's the Colorado Commission of Indian Affairs at the Lieutenant Governor's office to reach out to potentially some folks that could come speak to that subject that are from the Ute Mountain Ute and Southern Ute tribes.
Dr. Estes.
Just as an aside, it would be good to reach out to all the tribes in Colorado, not just the Ute, although they are very strong on good spokespeople. What I'm hoping that we will be able to do is make a set aside for what is called, as I understand it in Colorado, indigenous means a person who's enrolled in a federally recognized tribe. It is not used in the way that many of us use it, which is to say that the people who inhabit the land from ancient times forward are indigenous, and their descendants are descendants of the indigenous people. So what we're hoping is not to interfere at all, because they are sovereign nations. They're federally sovereign nations. And we, they already have hundreds of years, if not thousands of years, of ceremony and healing ways that are already intact and are handed down within generational lines. So we'll see what happens, but I'm hoping not at all to have any regulation of what they do. The same way we don't have regulation for religious counselors in recognized churches. In terms of mental health practitioners, if someone grieves against a therapist who is attached to a church and who is doing a kind of therapy that perhaps is not acceptable to, say, the APA, which is the American Psychological Association, to my knowledge, we have no jurisdiction, because the church has jurisdiction. And there's a set aside in the Colorado Revised Statutes that says that the churches are a separate entity all to themselves about what they do, how they do it, their ethics board, their grievance board, and so on and so forth. So setting that aside just for a moment, I wanted to say about the training of people. we have in Colorado, we're one of 2 states, I believe, there might be 3 by now, that has a registration for psychotherapists who are trained in other ways rather than getting a PsyD or a PhD or a marriage and family license or a LSW. And what they have to provide for the state of Colorado to be fit, to be understood as competent to offer services, is their training. What are you trained in? It's like what Dr. Goodwin said, equine training. The person he's speaking of has vast experience with horses who are considered spiritual beings by people who are spiritual, religious, indigenous, and so forth. They're considered our helpers, healers, and our friends. So that person will have to show to the state of Colorado they have training in how to approach patients, in how to teach patients, in how to interact the equine relatives, familiares, we call them, with human beings. And I would like to see something like that here to help to qualify people that already have training, but in an unusual or what we call non-traditional way, so that they can, I'm not sure about the word licensure exactly, but so that they can be registered and they have a board watching over, meaning a grievance board, essentially. And so the public has public safety in that regard, that there is someone watching for the best interests of all people. And that means that some of the educational backgrounds and the experiential backgrounds will be non-traditional. Thank you. That I meant to speak to, supporting people who have unusual backgrounds or training, who are very valid often in what they do in their effectiveness in helping and healing.
Thank you. Dr. Goodwin.
I think, as I said on the emergency response and safety board as well, and we're having to talk about what type of safety plan we're going to require in place for people who are going to do this, and in terms of health equity and public health, there are going to have to be some regulations. And Dr. Estes mentioned yesterday, like, if you grow some of these substances and toxic chemicals and these things, that could be very bad. So there has to be some level of regulation of kind of what we expect if we're going to give someone the blessing from the state that they are cultivating at least to a certain way. And when they build their safety plans, they're going to have to be so, they're going to have to meet all of our requirements. And so one of the challenges that we're going to face as a subcommittee for every kind of policy that we push out as a board is it reasonable for someone who doesn't have a lot of money? So for example, I don't want to require a state-of-the-art alarm system, for a facility that's going to cost $10,000 to install, because that would be a barrier to access. And so I think we can like extrapolate that across every decision we make is, we do want safety and we want quality and we want to make sure that people are providing a safe product out there and they're exchanging it. But we also want to make sure that what we're asking isn't so difficult that people of various statuses can't access it. And so I think, all of the stuff is going to have to flow through us, and we're going to have to look at it from that lens, saying, well, could someone who is economically disadvantaged actually comply with this? Is this reasonable? And I think one example is that, and I didn't read all of Prop 122, but and I think the bill that Senator Feinberg was putting out, something that was putting a cap on the space where you could grow psilocybin. It was like 12 by 12 or something. You know what I'm talking about? Anyway, there's going to be a lot of things like that where we're going to have to look and really put that lens on there and say, is this restriction, this regulation that we're about to create, is it reasonable, to do? That's it.
Um, let me find my hand.
You don't have to. It's okay. Gotcha. Go ahead.
In let me see. What is going on? How do we make it? What measurement? Hold on. Purity should be in here somewhere, in terms of public health and health equity. Because talk about health. On what Dr. Goodwin is speaking about is the fact that so much of the soil in the cities and villages has been poisoned over the years of pesticides. Psilocybin is going to be consumed physically, eaten. It's not synthesized. And as far as I know, there would be no refinement of it once it comes out of the ground. So having some concept to recommend to the legislatures about what is our standard for growing that will be part of health equity and public health, because we don't want people to be ingesting things that are grown in contaminated soil. This is important. Some people have autoimmune disorders, and they are likely to be recipients of some of this kind of natural medicine. And they may not be able to tolerate, some of the things that are in the plant as a result of being grown in soil that is not clean. So somewhere in there, I'd like to add that idea of how do we make a protocol for the grower, the private grower, the one-person grower, that at least gives some guidelines about how to do this in the most healthy way possible, so they do no harm unwittingly. Thank you.
Director Gonzalez.
So Dr. A, you bring up a good point, and I don't know if this is a point you're trying to make, but this is what I got out of what you just said. And so for question 2, how do you support marginalized population in obtaining a license to succeed in cultivating, facilitating, or healing center arenas? Currently in Colorado, and I don't know if this is a question for the Attorney General's office, if you have a medical condition, are you able to grow in your own home and be your own facilitator or be your own kind of personal provider? You can. And so
You can grow your own. You can grow your own. You can share it under Prop 122.
No, currently, like today or yesterday, if I was growing it, I could. So would the recommendations now be, in order to do that, you have to be licensed or at least notify someone that you are growing?
So go ahead, Dr. Goodwin.
I thought that was just if they wanted to sell it, buy and sell it. Because right now under Proposition 122, you can grow it and you could share it. But I think if we're going to get to the place where there's commerce, buying and selling, then we have to figure out how that's going to work. If they're going to be licensed, or if the facilitator can do it, or the healing center can do it, or anybody can do it, right? Please correct me if I'm wrong.
I see where you're going, but I think where my brain went is a lot of the like ODs that we're seeing for people with fentanyl is because they can't get the prescription. So they're going out to the streets, but then they're cutting it with something else. And that's what's getting them sick. So you can't really go out there and regulate what the dealers are doing. And so that's I'm wondering if under this, to be safer, that you're also saying if you're growing and sharing, you're also going to be regulated as to how you're doing that. And that's kind of where my brain went when Dr. Estes was talking, like, oh, are we actually going to also work on that piece as well?
I'm sorry, I didn't mean to cut you off. I think Sam and Brian have some clarification on this point. Sam,
I was going to actually pass it to Brian. I'm not sure if you caught all that. I know you have like a slight delay right now.
Yeah, so it just basically sounds like Dr. Gonzalez is asking specifically about like the personal use exceptions that are currently in state law that allow you to grow your own natural medicines, and whether or not you can regulate that. The way that the statute is structured, there's two buckets: personal use and then regulated access. And so the charge of the board is regulated access rather than personal use, if that makes sense. So it's kind of outside of your purview.
Thanks, Brian.
Yeah, hopefully that made sense.
I think Dr. Goodwin is first, then we'll get to you, Elisa.
Yeah, Dr. Henry. Yeah, so I have an idea for this. The Germans do this really well with their beer. In Germany, they have a purity law for their beer. And in any type of German beer, you can only have 5 ingredients, right? It's like water, hops, barley, and whatever. And so Germans do 5 types of beer only. And when you get beer there, it's you want a Pils or you want a Helles, and it doesn't matter. Like it's not like Colorado where you have all these craft beers and you can do whatever you want to it. They've kind of created this purity law in Germany. And I think there are some mycologists and some experts on on the board, but if we could kind of get a list of like, hey, what do you need to grow a healthy pure psilocybin, and just make that list. Like these are the only ingredients you can use in order to be a certified by the state facility. So you can't use any of these pesticides. You can't use these are the allowed substances you can use in the growing process.
So
It might make
yeah, I think this is a question for products research and data, specifically regarding cultivation standards as it relates to the regulated model, and testing standards as it relates to the regulated model. And I think that what the work in that model, the work in that subcommittee would probably be a good model for educational standards and the materials that'll be given out. And I guess we'll see what happens in there. But that, I think, related to these specific questions around grow, soil contamination, as Dr. Estes had pointed out. I think those will all be questions for the Products Research and Data Subcommittee.
Thank you. Dr. Estes.
We will also take that up in the Indigenous, Spiritual, and Religious Subcommittee tomorrow, because purity is a word that might be taken wrong, as in as in perfection. Nothing's perfect, but things can be really good, and they can also be made better. And spiritual and religious people have many things to say about ingestion of things that are good for you and things that are not good for you, physically and spiritual. There's a whole vast realm of things to eat or not eat in the Old Testament, in the New Testament, in Muslim Quran, in people who follow nutritional ideals and so forth. So we will take it up a little bit in ours as per the spiritual aspect, the religious aspect, and the indigenous aspect. And that's one of the things I hope that I've been at almost every meeting since we started, every subcommittee meeting. And what I see is tremendous progress. Even though you're trying to drink out of a fire hose initially, I see that stream getting narrowed and narrowed, being able to be grounded and supported with ideas that are going to be advisements to the larger legislature. And I just wanted to note that I think you're coming along very, very well. And I like the idea of what you call bucketing. That's a very interesting term. I've never heard that before, but thank you.
Thank you. I wanted to kind of call us back a little bit to the question, the second priority question that we've agreed to move to around barriers to ensuring health equity. And I want to reflect a little bit what I heard earlier around on the side of the people delivering services and cultivating the products, that we talked a little bit about kind of the cost and maybe the regulatory complexity of getting licensed to do those things is a potential barrier to health equity, not that appropriate regulation, as we've been exploring in the case of quote unquote purity of the products. I think that part of our subcommittee's charge is trying to help the broader board strike a balance with ensuring high quality care, right? Ensuring high quality medicine, et cetera, and also promoting access and diversity in the delivery of services and products to patients. So, but I think, the ways in which we, the training that we establish, that the licensing committee establishes, how much is that going to cost? And in terms of the regulatory environment, like for healing centers, for example, maybe here's where some of the marijuana analogy comes in. To the degree we're talking about brick and mortar locations, that right there, of course, is a tremendous cost. And in terms of the regulation, there's an overlap between cost and complexity. I think complexity is also a separate issue, because if you are in a population that current societal circumstances, advantages, then it's going to be easier for you to navigate regulatory complexity, cost aside, than a member of a population that's more marginalized in terms of, connections and those types of things. So I think those are important factors for our subcommittee to be mindful of.
That's good, Mr. Wynn. I like the way your mind works. It's really precise. It's like Dr. Rodriguez's mind too. It's very finely tuned for detail. Really beautiful.
I take all the compliments I can get. Thank you, Dr. Estes. So noted. I want to share your recognition of the progress that this subcommittee and other subcommittees are making together, all of us. I wanted to pose to the subcommittee just to ask us to consider briefly if we want to talk about barriers more on the patient side. And I'll throw one out. I think a particularly obvious one is cost. We're talking about with the 3-step process, which I personally support. That's a lot of hours of somebody or multiple people, supporting patients through that process. And even for a kind of reasonable value of each hour, you're starting to get to a pretty expensive proposition. So there I think we have a pretty meaningful challenge. And of course, like the degree to which we can actually regulate pricing, I think I don't know the answers to those questions. We'll have to do some work around that, where our authority begins and ends. But that's one barrier I immediately think of when I consider barriers to equitable access. Dr. Gonzalez.
So now that I understand that someone can actually grow their own, I'm curious if that would alleviate the cost aspect of it and would play into the education kind of marketing aspect of it. Because I don't think there's a standard milligram or dosage that has been created for whatever element you're trying to treat. But I think if someone is able to grow their own in their home, then the marketing and to make sure that they're under someone who understands, and I don't want to say a licensed person, but for the lack of better words, a licensed provider while they're doing it. So I'm not too sure if that plays into the kind of marketing education piece as well, the different ways you can access.
So just to clarify, like it's best if you keep the 2 access programs or the 2 provisions of the statute separate in your mind. Like there's regulated access, which is what you guys are doing, and then there's personal use. If someone is growing psilocybin and they're trying to like sell it to people, that's not legal under the statute. That's not regulated access. So you can't be advertising it. You can't be selling stuff you're growing yourself. I think just to keep your stuff on topic to the regulated access program, it's really hard to do because obviously the personal use exception that's currently in the statute is really, really broad and it kind of encompasses everything. I would just try to stay away from the personal use exception unless your duties of the board bring you to the issue of like, how do you regulate unlicensed practice? So someone who is growing and selling on the black market, that's probably like the only time I could see this board advising on the personal use exception, but otherwise I would just try to keep it out of your mind.
So how do we regulate costs?
cost for the program and the growth. I mean,
Not the
that's
growth to purchase it, to use. So if you can't regulate the personal growth, then how do you regulate the cost?
so anybody who would be
Not the personal use. If I'm a facilitator, I can prescribe. I'm now growing and selling and prescribing. How does this board regulate then how much you charge if cost is going to be one of the areas that we're looking at for patients to go purchase?
so
How do we know it's a bear if we don't know what the amount is?
I think that's a fair question. But I think that's separate from personal use, right? So like if you're a licensed facilitator, you still can't grow your own psilocybin and to distribute as part of the regulated access program, because that's still going to be regulated under the system. But
and
to your greater,
I understand that. But I know like OxyContin, the reason it exploded and the reason it was so easy to get is because even if you had a prescription, the cost was like so cheap. Like you can pay $12 and get a 30-day supply. And that's how addiction started. So I'm kind of curious, like we're looking at cost, and if we're looking at cost as the access health equity, then I would assume then we would have a voice to regulate what the cost looks like if you're going to impact equity.
But I think that's a good question, and I think I'd like to add that in and see if I can pull some materials to see what cultivation costs, what that might be similarly to how MED did that. Not exactly, but I think it would be interesting to see how costly is cultivation, right? Especially in a regulated model, and what that entails. Because I guess right now, right, the facilitator, we haven't decided, right, but a facilitator could potentially, or the healing center could potentially also cultivate and test potentially. And those would probably be different licenses, and the cost could be potentially be different. So that's a good question. Let me, if you can frame that again one more time so I can make sure I have that in my notes correctly. And let me see if I can reach out to some folks and see if we can get anything that might help answer that.
Yeah. So I think I hate it when you ask us to refrain because then I have to remember what I said.
I'm sorry.
So I think I was trying to answer Billy's question of equity for cost. But if we're tagged or if we're trying to look at equity, health equity in terms of cost, then are we then to regulate how much cost is associated with purchasing once you're prescribed? Is that what I said, everyone? Look, I upset Josh and he left.
Dr. Goodwin drop off.
No, he just ran out of the building yelling and screaming.
Okay. Dr. Estes has had your hand up, so I want to let you speak here.
Mr. Urankar, may I ask you who will be watching over the private growing so people come to no harm? How does that work in 122?
That's a difficult question to answer, but obviously there's the regulated access program. So if someone is personally cultivating and they do something that could run afoul of what is considered regulated access to the program, so like someone serving as a facilitator, then theoretically DORA could bring an enforcement action like a cease and desist or something like that against them to stop them from doing it. So that's kind of one prong. The other prong is obviously there's still criminal laws associated with it. So if you did something that violated criminal law, then law enforcement could also enforce. But yeah, as it currently sits in statute, the personal use exception is extremely broad.
I think in the coming weeks we'll get some further answers on that.
Okay, I was more concerned about people having enough education about dosage, about antidotes if necessary, if one has overdone it, for instance. when they're by themselves and they're trying to self-dose, or trying to do it themselves, in part for can afford to go elsewhere. The way that we in curanderismo approach all plant medicines is that you prepare for ceremony by purifying. It might take enemetics, it might take vomiting, it might take 2 days with only water, 2 days without food. You prepare yourself. Then you do ceremony, whatever it is, whatever that. Then afterwards you are walked with for hours and days afterward. That is considered the complete cycle. And I have a concern that people who might be self-dosing hopefully might be educated to know about what a full cycle looks like, so that, because you have to be able to process what you're experiencing after you're experiencing. And in Mexico, some of my colleagues who are psychoanalysts and psychologists, some of their patients have taken ayahuasca, for instance, and then spend weeks processing with them who did not give them the ayahuasca what had occurred, what they saw, felt, heard, and what they are integrating now. So that is why I'm asking the question about people who are growing their own and self-administering. Like, is anyone going to watch over or educate, or no? Yes? No?
So I would say that one of the charges of this, and I think you could drop it under number 4, your topic number 4 is educational materials. And I think that probably falls underneath your public health education charge. So it's a good thing to flag for future discussion of, like, what's the scope of your education materials? Does that include just general dosing information, things like that?
Thank you. Thank you, Mr. White.
That's a good one.
Sorry, I had to take a quick bio break, but my restroom is right next door, so I was following everything, heard it all. I would say just a couple of things. One, I'm not a super big fan of regulating the cost of this. Just from being a small business owner, it's going to cost what it's going to cost. Brick and mortar places cost, power's going up, water's costing more, and so if you regulate the end product, you don't allow the person who's growing and developing and running that business to kind of flex with the economy. So I think capitalism will do it. If they're too high, then they're no longer in business. But I will say that there is one place where the personal use and the regulated access model will overlap, and we're still trying to figure this out in the emergency safety committee. It's the idea, if you're doing facilitation or one of these healing centers in like a residential neighborhood, are we going to require the facilitator to provide the substance so that they know the origin of it, the dosage that they gave, they know exactly what it is, or are we going to allow them to let the client bring in the substance and they just facilitate? Because our question from that angle is, if there's a medical emergency and paramedics come, do we want the facilitator to be able to say, here's exactly what they ingested because I gave it to them, versus someone brings in a brownie that who knows what's in there, right? And so, but where that bumps up with the health equity thing and is the idea of, it's expensive to grow. It isn't as easy as like putting a seed in a pot, putting some water on it and throw it in the windowsill. I mean, there's a whole thing that's got to happen to cultivate mushrooms. It's very difficult to do, and so it's expensive. And so the best option there is to go buy it from somewhere. And so, then we have to decide, like, the facilitators, if we are going to require them to do it, they need to be able to charge and get reimbursed for that time, or if we're going to allow them to bring it in. And so we're going to have to make those decisions, because there's going to be cost there, right? And we just want people to get compensated fairly for their time. That's it.
Yeah, thank you for those comments. And I guess there's a question for Brian, just since Dr. Goodwin raised it. My gut belief is that the law requires that the medicine that's delivered be grown by a licensed cultivator if it's going to be under the, delivered under the regulatory model. Is that accurate, or is Dr. Goodwin's scenario conceivable where a patient would bring their own medicine to the otherwise regulated services? And maybe you can tell us next time if you don't know for sure. But
I want to say yes, but yes, it has to be grown within the licensing framework. However, I'm hesitating because there's a lot of gray area with facilitation in the current statute. So I could look more deeply into it and try to get back to you with a more informed answer.
I did also want to go back to Dr. Gonzalez's point, because one way that we might think about it is there's also things Dr. Goodwin was saying, there's like it in healthcare, like there's the sticker price, right? I mean, there's, which is kind of whatever the facilitator et al. Are charging for the delivery of the services. And then there's the price the patient pays. And if the service is covered, for example, by insurance, then typically the patient's not going to pay 100%. They're going to pay, a fraction of that. I want to just go ahead and I will say to Dr. Goodwin's point that I agree. Whether I agree philosophically or pragmatically or politically, I'm not sure, but I agree that this subcommittee is probably not going to say the price of delivering natural medicine service is X. I would encourage us to think of some strategies that the state and kind of the system we're creating might use to help people who are uninsured or underinsured, or probably at least preliminary, it's not going to be covered even if you are insured, for all people, including people with low income, to be able to access the services as best we can, acknowledging reality and acknowledging we're probably not going to be able to actually pin a needle on the price that is charged. I have one example that just to share that is a quarter baked, but if some of the training programs, perhaps at a community college, perhaps other higher education college, would agree to train facilitators, for example, under a lower cost model or a loan forgiveness program or something like that, in exchange for them agreeing to deliver services to potentially marginalized populations, lower at a reduced fee or in a rural area or what have you, which analogs for that do exist in the healthcare system elsewhere. Or that's the kind of strategy that I'm thinking of that's short of dictating price, but might help encourage equitable access.
I love your idea of community colleges. That is beautiful, because that potentially would be very accessible to more people than the much pricier, Denver University, other universities that are accredited by North Central, for instance. And that will make it they do already EMT training. They do other trainings that are 1 year long that allow people to gain a certificate or in 2 years an associate degree. That's a wonderful idea. Mr. Nguyen, thank you.
Dr. Goodwin.
I like the idea of train the trainer, right? And so one of the things the community is going to have to do, this committee is going to have to do is for the licensing and to become facilitators and healing centers, we're going to have to set a cost for what that license is. And so we can come in and say, for people who are low income or whatever that criteria is, it's going to be a reduced cost, right? To be able to get in that license. But I would love to create a trainer within this kind of infrastructure, so that let's say someone is low cost, but they want to become a trainer to train other people how to do this, that we could do that at a low cost as well. They complete the stuff and then they can go out and train others. And then that might be something that we could do, kind of through because the problem with community colleges, a lot of them are for profit, they're private, you can't make them do anything. But we could, create this like train the trainer program and get folks who are trained that would train others, and then kind of reduce the licensing costs for that. I think that would be interesting.
Sorry, finding the unmute button. Thank you. Dr. Estes.
I like that idea, Dr. Goodwin. I think that's a great idea. It almost sounds like peer-to-peer training that would, assuming the trainer is well trained, assuming the trainer is of goodwill, assuming the trainer is relatively free of all, egotistical ambition and really wants, to help people and help people help people. I think that's a really good idea. I keep reminding myself as I've listened in on the subcommittees and am chair of one of them, I keep reminding myself that we're not creating policy, we're trying to make recommendations, that our recommendations might be voted down, or there might be people who show up in testimony who have different ideas. And that's why I think, as Dr. Gonzalez said last time, figuring out who the core group is and then naming what would make that access equitable for all persons is so very important, because you're hoping to include all the people you possibly can, so that the objections to having safe and scientific and hopefully sacred too ways of administering this is not objected to, at least not, in a way that can knock something off track that is actually good for public safety and for the dissemination of plant medicine, which belongs to everyone. So I think that you're again, you're on the right track. And this is not easy, because essentially you remind me kind of and there was a face that floated over the void, and the face spoke the words, "Let the darkness be separated from the light." And then there were several more days of creation after that. It was a really big deal. A lot of creation. So it's something like that, except on a human level, that you're doing, I think. So creating a world that does not exist, but ought to, should, could, and must. So keep going, continue on, keep going.
Do we have any other comments on barriers to ensuring health equity, whether from the provider perspective or patient perspective? We've talked about cost and regulatory complexity, and I guess one other thing I would note is geography. Again, I don't know, and I think the marijuana model is an imperfect analogy, but those of us who live in metropolitan areas are probably going to have easier access to these services, I'm predicting, at least barring the good work of this subcommittee, than people in rural areas or in mountain areas. So I think we may want to keep that in mind as we make our recommendations as well. But other thoughts, Dr. Estes? Yeah.
I just want to give you a small model that already exists. Clínica Tepeyac is a Latino organization that is supported in part by La Raza, by the Catholic Church. And they'll show up at churches like La Señora de Guadalupe in Northwest Denver. They'll show up to give flu shots. I'll show up to give guidance counseling about safety in pandemic. There really could be groups of people who are of nonprofits or even for-profit groups that actually go to different areas and offer services at a much lower price than if a person was to try to do that, on their own. The churches amongst many African Americans or many Latinos are actually the place to disseminate education. if you're trying to figure out where to go and you want to hold a meeting, yeah, people might show up, but they might not show up because they have families and they have elders to take care of, and all kinds of things going on. But if you go to church, and they'll ask the minister or the priest, or the rabbi or the imam, if they'll ask, could I speak to the people about safety issues? They will very likely qualify you and say yes. So that's a whole other little model, or not so little, but a strong model, effective model that we could think about too, in terms of saying, well, look, here's another avenue. Here's another tributary to the river. Here's how we go to people and we educate them. So just saying, thank you.
Thank you, Dr. Estes. I want to pick up that baton and say that I think it would be helpful, Sam, for the subcommittee to hear from a community health center like Clinica Tepeyac. It doesn't have to be that one, but I want to note that and Brian, correct me if I'm wrong, but that the law allows for existing deliverers of healthcare services to qualify as healing centers, and that we may want to engage with healthcare providers who are accustomed to delivering service to marginalized populations, low-income populations, minority populations. Number one, to gauge their interest in participating in delivery of some of these services, but also just to learn from their experience and how to best equitably serve marginalized communities.
I should mention also that up-to-date information about Clinica Tepeyac and who they are sponsored by might not be, in the last year or so. As you know, people who rely on donations and funding and grants, it's a constantly shifting ground under their feet. But so they're always seeking new forms of funding. So exactly who they might be sponsored by now might be different than what I just said. But for sure, they are committed, heartfelt people.
I'm happy to reach out to them and any other clinics that you guys might come up with after the meeting. And if you just want to send me some folks that you are interested in specifically, I can definitely reach out to them to see if we can have them come in and help answer some questions.
Thank you.
Thank you, Steve.
So let's see. I'm wondering if we are at a point where I think maybe we're at a point where either we want to decide that we need more time, research information before we can feel like we have fully defined the barriers to equitable access, or does somebody want to make a motion that tries to capture the ground we've covered and consider if that's enough for now? So that that's an open-ended question for subcommittee members to comment on where we go from here with regard to this second priority question that we're talking about right now. That's a good one.
I'd like to put a pin in it, and I love what Dr. Estes and Dr. Gonzalez both, and you too, Chair, about not reinventing the wheel, and that maybe that there are groups of people out there who have already kind of identified a whole bunch of these barriers instead of like trying to recreate it ourselves. It would be great to get someone, if there's a nonprofit who's already kind of working on this, or I know the big psychedelic conference is coming to Denver in June, and I know that they're doing all these talks. I'm not familiar with who the leaders are kind of in this space, but if there was someone who already kind of had identified this, I'd love to hear from them. That way, we get kind of a better picture. But I would be open to making a move to just put a pin in where we're at now until we hear for some experts, if that's what you're looking for.
And Dr. Sicily, Susan Sicily, is an MD and a mycologist and a researcher. I'm sure she could answer some of the questions that were asked today about what generally is dosage. How do you plant mushrooms, make them thrive and be nourishing? And so I hope, Mr. Barami, that you'll ask her. I'm sure she would tell you immediately. Thank you.
All right, so I move to put a pin in it until we hear from more experts.
I second. Dr. E.
All in favor of I'll phrase it as continuing discussion of the second question around defining barriers to ensuring health equity in this arena. All in favor of doing that, please say aye.
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 Okay, any no's or abstentions? Okay, sounds good. I did want to quickly flag, I wonder, I agree with Dr. Goodwin, there certainly are excellent organizations in our community dedicated to this question, and I'm sure could help us understand the barriers various populations face in accessing healthcare services. So I want to consider inviting some of them to share information with us. I also wanted to, I bet that commission that Dr. Gonzalez referenced at the very beginning of this conversation has probably engaged, I don't want to assume, but we should find out if that commission has engaged with a lot of those community experts as well, and maybe they've already derived, in addition to their definition of health equity, some insight into the specific barriers people face in accessing services and becoming providers of services.
Good.
So that might be maybe that's to you, Sam. Or I guess if we're all going to get that commission report, we can take a look at it before the next meeting for clues
Yeah,
about that.
I will send out the healthcare policy and financing the report. I will also reach out to them to see if anyone from their commission or staff could come and speak to the board about their plan and what they produce, as well as I'll look at finding resources around community healthcare clinics, as well as materials as related to cannabis cultivation costs, cannabis equity costs. There's actually quite a few materials already out there. There's also cannabis education pieces, as well as safety standards for folks in the facilities. So I think that'll also go with products research and data. So I'd like to get a packet out there for all these resources and kind of define them, but I'll send these pieces out and the equity plan after the meeting.
Thank you. If I may, there's one other thing I wanted to ask about getting information about, which is the cost. To get a sense for the cost, kind of where the market is, understanding that the current market is underground. But if there's a way to glean some information, I mean, and maybe I shouldn't put it quite that way, but it's not yet regulated by us. I can feel safe saying that. What the kind of going rate range of costs of these services are, at least starting within the psilocybin space, I think would be helpful. Information for us to know as we wade into these affordability issues.
I think that's really good. I think you're going to find 3 tiers. As I've researched on the internet, some of them are astronomically priced for a 3-day, whatever, wherever. Some of them are moderate, like what I would say, what the average price is for an hour of psychoanalysis in Denver, or an hour with a psychologist in Denver. It's a pretty moderate price often, although some are higher than others. And then very, very low price that come from people who often have a healing practice that is dedicated to a religious ideal or a spiritual ideal. And sometimes their prices are very, very. So I think you're going to find 3 different tiers. And the question I would have then for you and other people on the subcommittee is, we've never, as far as I know, in Colorado, regulated price of practices for lawyers, doctors, helping professionals. But as you know, for some people, business comes before calling. For other people, calling comes first, and then business comes equal to or second. That seems a lot of the determinant of what people might create open doors with, depending on how they feel about doing what they're doing. You know what I'm saying? Not to say anything is wrong, just saying it's different. Those 2 attitudes. Thank you.
Any other, so I think we've covered a lot of ground. We have given Dora some requests for more information. Are there any other comments, questions that subcommittee members want to raise or that Dora wants to insert before we move toward closing our meeting? All right, seeing none, I'm going to pull up my script here. Give me a moment. I would like to thank everyone for your attendance and participation during today's meeting. Before we adjourn, there are a few items to be addressed. The next meeting will be held on May 18th, 2023 at 1 p.m. Please remember that your attendance is necessary to ensure a quorum for the meeting. I also need to call for attestations and affirmation with regard to conflict of interests. So I'm asking you, each board member, do you attest and affirm that all conflicts of interest have been disclosed and that confidentiality of all board matters has been maintained since the previous board meeting? I'm here first, so I'll go ahead and say my answer is yes. Dr. Gonzalez.
Yes.
Thank you. Dr. Estes. I'm sorry, I didn't see you. Did you make a motion? Did you say yes?
Yes.
Okay, thank you. I'm sorry. I didn't hear. Dr. Goodwin.
Yes.
Thank you. Is there a motion to adjourn?
So moved, Dr. Goodwin.
Is there a second?
I can second.
Thank you. This meeting of the Public Health and Health Equity Subcommittee, Public Health and Health Equity Subcommittee is adjourned. Thank you all very much.
Thank you. Dios te
Great job, Chair. Thank you.
Thank you.
Yeah, thanks for the
Practice.
Dios te bendiga. May you all be watched over. Kept safe until we see you all again. Adios.
Thank you.